Hello everyone. In this talk, I want to discuss with you about a very common clinical problem in adult urology practice. This is occurrence of recurrent urinary tract infection in a patient who has prostatic enlargement. Now, whenever you are faced with the problem of recurrent urinary tract infection with prostate enlargement, the common perception is that UTI is occurring on account of a subclinical or manifest bladder outflow obstruction. And that is what most of the time presumed. And you treat the patient accordingly. But is that matter so simple? The recurrent urinary tract infection, as you are well aware, can happen on account of a myriad of host factors, such as the age, presence of diabetes mellitus, lymphoproliferative disorders, patients on chemotherapy, patients on radiotherapy, HIV victims, transplant recipients, and many such similar factors which reduce the infection fighting potential of an individual. Now, this is a very common knowledge to anybody who is having recurrent urinary infection, and this applies to this subset also. And I am not going to detail this here. What I want to talk to you about is what are the main urologic factors which result in recurrent urinary tract infection here, and what are the major microbiological factors which are responsible here. Let us see first the urologic factors. The reason for persistence of infection in this patient who is having prostatic enlargement, as I said, very commonly it is believed to exist within the bladder. But friends, it can exist within the prostate, the focus of infection I am talking about, or it can exist within the pelvic system, or it can even exist within the urethra. So apparently there are 4 sites where the bacteria may be living in a hideout. Now, is it clinically possible to pinpoint these sites? It may be single site or it may be multiple site in the patient. So can you clinically pinpoint these sites? That is the question, and that is the point of relevance here. Let me talk about these sites one by one. What do I mean by these sites? Why infection can stay at this site? And is it for you possible to clinically diagnose this? So first, within the bladder, the common perception is that it is the large amount of post-void residual urinary volume which is responsible for this, like here. And this large PVRU can exist within the bladder lumen, or sometimes it can exist within the diverticulum, or in fact, in large number of patients, it can even be without significant PVRU, and this happens when patient has thick-walled bladder with obstructive flow, and urodynamically this will be a high pressure voiding. So on account of high pressure voiding alone, there can be persistence of urinary tract infection. Is it possible for you to clinically diagnose that in this patient the seat of problem lies within the bladder? The dominant clinical features in this situation will be patient will have these low urinary tract symptoms, frequency, urgency, incomplete void, which anyway are present in a patient of prostatic obstruction. But remember, a patient complains of 2 more symptoms: passing turbid urine or passing odorous urine. If that is the case, he may be having large PVRU which is infected. On ultrasound examination, you can see this thick-walled trabeculated bladder with or without diverticulum sometimes, or a large post-void residual volume, and you can see echoes in the urine on ultrasound. If you do a urodynamic study of this patient, you may either demonstrate high pressure voiding or may even demonstrate underactive bladder. Both variants happen because both these things can result into significant post-void residual urinary volume. So that is how you can identify that there is a major problem with the urinary bladder as a site for bacterial hideout. Let's talk about the prostate, the site 2. Now within the prostate, there is a very common association of prostatitis along with BPH. All of us have operated prostate glands by transurethral resection, and a number of times we discover micro abscesses reroofing, right, during the prostate gland, and biopsy report showing you the prostatitis. So this is what I'm talking about, that you may have either a non-suppurative prostatitis, which means there is no pus formation, and this begins with chemical insult to the prostate. And I have seen this in number of patients who have hyperuricemia. The uric acid crystals flow down the prostatic urethra. They even go within the prostatic ducts and initiate chemical prostatitis. Subsequently, this chemical prostatitis can become bacterial prostatitis. In other patients, you can have prostatitis with pus formation, the suppurative prostatitis, and these are prostatic abscesses, which can be micro abscesses or even macro abscesses sometimes. Now, can you discover this by clinical methods, that there is a seat of infection in the prostate gland in this patient? The dominant clinical feature will be here painful urination, painful ejaculation, and some degree of perineal pain, and some patients even complain of post-ejaculation burning during urination. They often have co-associated irritable bowel syndrome or constipation, and on DRE findings, you may even discover mildly tender prostate or even a bogey prostate if it is an abscess cavity. On ultrasound examination, I would say truss is hugely helpful in this scenario, which you can do in your clinic, and sometimes you will see change in the prostatic echo, even prostate calcification, and you will discover these ducts harboring these stones inside. So all that is possible by truss, and truss can also show you the occurrence of abscess when the disease gets more advanced, and you can see these hypoechoic collections, one place, two places, multiple places. So ultrasound truss is a useful test, but if you want more documentation, you can do this by MRI, which will show you tissue characteristics as well as abscess cavities. Moving to third site, which is within the pelvic-calyceal system. Within the pelvic-calyceal system, you can either have a reflux on unilateral side of both sides, or you can have even a stone in one of the calyx, or you can have even a secondary obstruction developing because of kinking in the ureter, and this is secondary PUJ developing because of long-standing reflux. You can have either of these situations in this patient. Clinically, how will you discover this? Again, the dominant features will be flank pain, fever with chills, and some patients can even have chronic kidney disease features. Ultrasound will show you these renal morphological changes very nicely, and you may even do investigations like CT urography or DMSA or DTP renal scan. Coming to fourth site, which is within the urethra, this place. Within the urethra, you may either have a catheter-induced urethritis, or you may have a catheter-induced stricture. Now, many patients of prostatic enlargement develop urinary retention and they are catheterized. And as a consequence of catheter, you can have either of these. how will you discover this? You will discover this by the patient complaining of dysuria and thinning of the stream. In a patient of BPH, this urinary stream classically loses projection. The caliber is maintained. But when they develop stricture, in addition to it, the stream becomes thin and thinner. On ultrasound, nothing remarkable except trabeculated bladder and enlarged PVRU. But then the key investigation is retrograde urethrogram, which will show you either urethritis like this, where you will see a prominent litter glands visible as a result of catheter reaction all over, or you may even see a urethral stricture again as a result of catheter, or you may sometimes see these ducts also. So I told you about these 4 sites which can be the places for bacterial hideout and resultant recurrent urinary tract infection. Now, why I am telling you about this thing? This is a big question. Why at all you should know that at which site there is a persistence of infection? There are 2 aspects. One, you select antibiotics which is best suited for the site. The concentration of that antibiotic should be good at that site. And secondly, you select an appropriate procedure to correct the obstruction or suppuration, whatever is the case. Let's see about this. What I mean by saying select suitable antibiotic appropriate for the site. By this I mean that antibiotics have a differential concentration in various parts of the urinary tract. The concentration within the tissue in a given antibiotic may be different in renal parenchyma or may be different in prostate and prostatic glands. Or the concentration may be high in urine, not much in tissue, right? So when you talk about antibiotic concentration within the lumen of urinary bladder or within the dilated lumen of pelvic ileal system, then this is a different perception. So you should understand these 2 things clearly, that the antibiotic in question, how much is its concentration within the tissue and how much its concentration within the urine. Talking first about concentration in renal parenchyma, and for managing renal infection, we have these common 5 antibiotics which have a very high degree of concentration in renal parenchyma. But even within these 5, fluoroquinolones, trimethoprim, aminoglycoside have high. 3rd generation cephalosporins have moderate degree. But when it comes to their excretion in urine, the picture changes a little bit. And this is, fluoroquinolones continue to remain very high. Trimethoprim is also very high, but aminoglycosides become a little less because they are excreted by tubules, and tubular function can be deranged in a patient of obstructive uropathy. The cephalosporins are also high and carbapenems are also high. So please see this change of antibiotic concentration within the parenchyma and then in the urine. When it comes to prostate, the prostatic parenchyma is a different ball game altogether, because the prostate cell has an acidic membrane, so it does not permeate perfusion of antibiotic across it. And in old days, we used to say there's a blood-prostate barrier, something similar to blood-brain barrier. So this barrier does not allow antibiotic concentration. And if you see these 5 antibiotics again, then please remember that in a relatively normal prostate, or in a relatively, I would say, a prostate which is not very badly inflamed on account of acute prostatitis or acute abscess, where this prostate barrier is broken, right? In chronic prostatitis, in simple BPH, this barrier is maintained. In place of these 3 antibiotics, we have macrolides, tetracyclines, by which I mean doxycycline, and then in place of carbapenems, clindamycin. So don't use those 3 antibiotics when you are treating chronic prostatitis. But when it comes to the concentration in ducts of prostate gland and as well as periurethral glands, picture remains more or less same, but fluoroquinolones and trimethoprim have very high concentration, and macrolides, tetracyclines and clindamycin also maintains a same degree of concentration. So this concept should stay in the mind of you when you are treating the case. Now then there are two antibiotics which are very commonly used in management of recurrent urinary infection, and this is nitrofurantoin and fosfomycin. So nitrofurantoin, how well does it concentrate within the renal and prostate parenchyma? That we must know at this point of time. Now the nitrofurantoin is one drug which gets excreted almost 100% in the urine. So it has a very high concentration in urine, and that is why it is such a popular drug for treating recurrent urinary tract infection. But friends, please remember that in renal parenchyma, it has very poor concentration. So it is not a good drug for pyelonephritis. And in prostate tissue and in the prostatic fluid, it has very, very poor concentration. It does not reach the prostate parenchyma at all. So the clinical implication is that nitrofurantoin should not be used for treating acute or chronic bacterial prostatitis or even acute pyelonephritis because it fails to reach effective concentration. For fosfomycin, does this concentrate in kidney parenchyma and prostate parenchyma? Again, this also has a very high excretion in urine. That is why it is a popular drug for recurrent UTI. But if you are treating renal parenchyma infection, its concentration is poor. So sometimes people use IV fosfomycin, particularly in ICUs. In prostate fluid, its concentration is very, very low. And I'm sure you are aware, I am also aware of some instances where people have used a higher dose of fosfomycin, more frequent dosing of fosfomycin to manage some strains of E. coli in chronic prostatitis. This is coming nowadays, but then it is not a regular clinical practice. So the bottom line in reference to fosfomycin should be that for renal parenchyma infection, only IV, not oral. And for prostate, repeated oral dosage can sometimes be used, but don't make this as a first choice antibiotic to treat prostatic seat of infection. So friends, what I am trying to say, choose antibiotic as per the site of infection. For kidney, choose any of these 5. For prostate, fluoroquinolones is fine, trimethoprim is fine, but then these 3 are better. And the same applies for urethral glands also. But when you are treating infection in bladder lumen because of large PVRU, choose nitrofurantoin or choose fosfomycin, right? Or you may choose any of these 3 also. Now then coming to second question, why should you choose the site? Second aspect is you have to select an appropriate procedure to correct that abnormality which is resulting into recurrent infection. If it is in the prostate gland, if it is obstructive prostate, the patient will require prostatectomy of some kind, laser, bipolar, whatever you do. Or if it is infected prostate, you may even do truss-guided aspiration and you may even do transurethral resection. I have separately put a video on YouTube on how to do a TURP in a patient who has developed prostatic abscesses. When it is a bladder case, if it is high pressure bladder, you will have to do either bladder neck incision or TURP. If it is underactive bladder, you will have to resort to clean intermittent catheterization. If it is in the pelvic system and stones are responsible for it, you will have to remove the stones, right? And if it is renal infection, you have to treat appropriately, whether it is renal parenchyma, calyceal diverticulum, pelvic system, whatever. If it is urethra, urethritis sometimes responds to long courses of those antibiotics which are referred to, clindamycin, doxycycline. Sometimes intraurethral application of antibiotics also works. But if it is stricture, you need either a DVIU or a urethroplasty. So the site will require proper addressal. So much so about urologic factors. And coming quickly to microbiologic factors, which are also important here. First microbiologic factor is pathogen. When you treat a case of recurrent UTI, keep pathogen in mind, and you can have an idea about the pathogen if you know how that pathogen has come in the urinary tract in the patient. What was the source? In large number of patients, the source is indwelling catheter. Or in some patients, even a urological procedure like a cystoscopy or a trach biopsy. Or in some patients, it can even be large bowel where there is chronic constipation or IBS and bacteria through translymphatic route, sedal from rectum to prostate. The type of pathogen. The type of pathogen may be bacterial, or remember about fungal also in some patients of prostatic enlargement, because the catheterization 2-3 times can introduce fungal infection, particularly if it is a diabetic individual. In some patients, even it can be a virulent or resistant pathogen if the patient has had a catheterization in ICU or in a hospital setting somewhere. So just by knowing that how the pathogen entered, you can have an idea about the susceptibility of that pathogen, the resistance pattern of the pathogen, the type of pathogen, right? Say for instance, E. coli you get community acquired, but Pseudomonas klebsiella you get in a hospital, right? So the lessons that I want you to learn from my talk about the managing recurrent UTI with prostatomegaly is that please evolve a site-based strategy where you have to suspect which site, then confirm that site by proper investigations, and then eradicate that source. Keep pathogen in your mind. You will know this by the source, from where the pathogen has come, the type of pathogen, and then the resistance pattern. And finally, also remember some very common basic reasons which operate so frequently in this setting, and that is drug default, because patient is elderly male, they often forget regular dosing of antibiotics. Blunderbuss therapy, which sometimes they do on the advice of their friends and neighbors, family members, and even a fluctuating diabetes control. So I hope you got my point, and thank you very much for your patient listening. In case you have any comments or question, please feel free to write it on my email. Thank you very much.